Welcome. In this clinical review, we're going to break down psoriasis. We'll be focusing on the key information that really matters in your day-to-day practice, everything from getting the diagnosis right to managing those tricky systemic complications. Now, this entire explainer is based on the fantastic and comprehensive work compiled by Dr. Mohammed Al-Nagi Mohammed. We want to give full credit for this excellent resource. So with that, let's dive right in. So let's start with the number, 2%. That's about how many people in the population have psoriasis. So yeah, it's a pretty common condition that we all see. But here's the thing you have to grasp right from the start. While you see it on the skin, its implications are systemic. They run much, much deeper. It's now really well established that patients with psoriasis have a higher risk for a whole host of other issues. We're talking psoriatic arthritis, cardiovascular disease, metabolic syndrome, and even venous thromboembolism. The takeaway here is crystal clear. This is not just a skin condition. It's a systemic inflammatory disease. So to tackle this, here's our game plan. We've got 5 key areas. First, the why and what of the disease, its pathophysiology. Then, how to diagnose the different subtypes. Third, we'll cover first-line management for the most common type, plaque psoriasis. After that, advanced treatments, and we'll wrap up with systemic complications and when to refer. All right, let's jump into section 1, pathophysiology and presentation. This is all about understanding the fundamental why and what behind this disease. Psoriasis is truly a perfect storm of factors. On the genetic side, there's a really strong link to specific HLA types. Get this, there's a 70% concordance in identical twins. Immunologically, the whole problem boils down to abnormal T-cell activity that basically tells skin cells, the keratinocytes, to grow way too fast. And then you have the environment, where things like stress, a strep infection, or even sunlight can dramatically change the course of the disease. Now, if there's one concept to understand about modern psoriasis treatment, it's the role of T17 cells. These are a type of T helper cell that churns out interleukin-17, and we now know this is a key driver of that whole inflammatory cascade. Honestly, this discovery is what paved the way for some of our most effective, targeted biologic therapies. It was a real game changer. In the clinic, this is why taking a really thorough history is so important because of all these common triggers. Simple physical trauma can actually cause new lesions to appear. That's the Koebner phenomenon. Alcohol is a known trigger, and a whole list of common drugs, beta blockers, lithium, NSAIDs, ACE inhibitors can make things worse. Oh, and so can suddenly stopping systemic steroids. Okay, so we know the why, but how does all this actually look in the clinic? That brings us right to section 2, diagnosing subtypes and features. Or, as I like to call it, recognizing the many faces of psoriasis. So the most common type, the one you'll see all the time, is plaque psoriasis. Those are your classic, well-defined, scaly patches on places like elbows and knees. Flexural psoriasis is kind of its opposite. It's smooth, not scaly, and it hangs out in skin folds. Then you've got gutted psoriasis, which looks like little red teardrops, and a big clue is that it often flares up after a strep infection. Finally, pustular psoriasis usually shows up with pustules on the palms and soles. Now here is a clinical pearl you absolutely cannot afford to miss. A staggering 80 to 90% of patients who have psoriatic arthritis also have nail changes. What does that mean? It means the nails are a huge, visible clue to what might be going on in the joints. Catching this early can literally prevent irreversible damage. So what exactly are you looking for on the nails? Well, the key signs are pitting, little dents in the nail plate, onycholysis, where the nail starts to lift away from the nail bed. You might also see subungual hyperkeratosis, which is just a thickening of scale under the nail. And in really bad cases, the patient can lose the nail entirely. Recognizing these is just so important. Okay, let's switch gears and talk about treatment. In section 3, we're covering first-line management, and we're going to walk through the stepwise approach for chronic plaque psoriasis, straight from the NICE guidelines. The pathway is super logical. It all starts with regular emollients. Then, for first-line treatment, you combine a potent corticosteroid and a vitamin D analog, applied separately once a day for up to 4 weeks. If that doesn't work after 8 weeks, you move to step 2, a vitamin D analog twice a day. And if you're still not getting results, third-line options include a potent corticosteroid twice daily for a short burst or a coal tar preparation. So why this combination approach? What's the thinking behind it? Well, corticosteroids are fantastic anti-inflammatories, but you can't use them long-term because of side effects like skin thinning. On the other hand, vitamin D analogs are safe for long-term use, but they're just not as powerful. So by using them together, you get the best of both worlds. You maximize the effect while minimizing the risks from using steroids for too long. But what happens when those first-line therapies just aren't cutting it? Well, that takes us to Section 4, Advanced and Specialized Treatment. These are the interventions that are managed in secondary care. Phototherapy is a real cornerstone here. The first choice is narrowband UVB, usually given 3 times a week. The alternative is something called PUVA, which combines a photosensitizing agent with UVA light. Of course, there are risks you have to counsel patients about, namely premature skin aging and a higher risk of squamous cell carcinoma down the line. When even phototherapy isn't enough, we start looking at systemic non-biologics. Methotrexate is generally your go-to, your first-line choice, especially if the patient also has psoriatic arthritis. But you'd reach for cyclosporin in a few specific situations. If you need to get things under control fast, if the patient has that palmoplantar pustulosis, or if they're planning on having a baby. And that brings us to our final and maybe most important section, recognizing those systemic complications and knowing exactly when it's time to escalate care and get a specialist involved. So this brings us full circle, back to our very first question. After everything we've talked about, is psoriasis just a skin condition? And the answer has to be a resounding no. Thinking of it that way means you're missing the bigger picture, and you could be missing some really serious comorbidities. The systemic burden here is huge. About 10% of patients will develop psoriatic arthritis. But on top of that, we see higher risks of heart disease, blood clots, metabolic syndrome, and we can't forget the very real psychological distress that comes with having a chronic, visible condition like this. So, when do you refer? The NICE guidelines are super clear on this. You refer if you're not sure about the diagnosis, if the disease is severe, covering more than 10% of the body, or if topical therapy has failed. And this is so important. You also refer if the psoriasis is having a major negative impact on a person's life and well-being. Oh, and one more thing. All children and young people get referred right at presentation, no exception. And finally, a massive point on safety. There are 2 scenarios that are considered dermatological emergencies. They require an urgent, same-day referral. These are suspected erythroderma, where basically the entire skin surface is inflamed, and generalized pustular psoriasis. These are true medical emergencies, and you need to act fast. You know, at the end of the day, managing psoriasis well means looking beyond the skin. And that leaves us with a final, really crucial question for our own practice. Given this undeniable link between skin inflammation and systemic disease, how can we, using a proactive, multidisciplinary team approach, fundamentally change the long-term outcomes for our patients? It's something we all need to think about.